Okay. Good afternoon, dear colleagues. I thank the ATS to be here today to speak on routine IMA grafting. These are my disclosures. My arterial grafting experience, 30% BEMA for the first 15 years, 78% BEMA for the last 15 years in 1683 patients, 4809 bypasses, 98% arterial grafts with 87 veins. Through the last 3 decades, use of BEMA has been studied in ever-increasing different subgroups, beginning in 1990 with Kachukas alerted us to the risk of increased sternal wound infection with BEMA. Then followed at least 10 studies suggesting BEMA benefit for diabetic patients. Others included BEMA in the elderly, age over 70 years, in urgent and emergent surgery, routine use by Pevney and Moore, in dialysis patients, in patients with reduced ejection fraction, less than 30% and 30 to 50%, and finally, BEMA in women. Pevney and Moore's study of routine use of skeletonized IMAs was indeed prescient for the year 2008. Particularly, 42.3% were in patients over 70 years, and 34.2% patients were diabetics. Let's look at the when for BEMA, the age cutoff. In 2008, Mohammadi, in a study of single and double IMA survival, reported that 65 years of age was the cutoff for BEMA benefit. When the paper came out in EJCTS, the age had dropped to 60 years. This is the data from which these ages came for the presentation. They used a value of 0.56, and for the paper, obviously the reviewers made them choose a value of 0.05. Ergo, this paper from our unit. We examined the survival of 5601 single and double IMA patients from 1995 to 2008 with a mean follow-up of 7 years, and thinking that age was an effect modifier, created a spline analysis which shows the relationship of hazard ratio for BEMA relative to SEMA across age. The solid line is the hazard ratio, and the dotted lines are the 95% confidence interval. A hazard ratio below 1 suggests better survival with the BEMA relative to SEMA. Conversely, the hazard ratio over 1 suggests decreased survival over the age of 70. This is analogous to what is written on our milk cartons. It says the milk is best before, but it does not say it is bad after. What do the guidelines say? Reference 547, highlighted in this paper, is our paper recommending BEMA up to the age of 70. Let's extrapolate. If the average age of most studies of cabbage population is 65 to 70 years, then BEMA could be considered in 65 to 70% of patients referred for cabbage. And even if only 2/3 receive BEMA, this would be much more than the 5.4% in North America, 12 to 15% in Europe, and even the 30% in Japan. How to maximize IMA length? Use the shortest distance as the crow flies. For the rema to the circumflex system, pass the rema through a hole in the pericardium near the SVC, through the transverse sinus. For our 2014 study on the harmonic scalpel of 1057 patients, the rema in situ to the circumflex system was possible in 91% of the time. The same SVC hole is used for rema grafts to the right or posterolateral branch. For the rema to reach the PDA, the rema is passed through a hole in the pericardium near the IVC. This is the same series, and in situ rema reach the PDA 89% of the time. The turn point of the IMA is at the pericardial edge, not at the heel of the IMA. As the rema is extrapericardial, reoperations may be easier. Here's an example of a rema through the transverse sinus to the marginal system. And here's a rema to the PDA via a hole in the pericardium near the inferior vena cava. You can see the turn point is right down at the pericardial edge. When not to use IMAs, true cardiogenic shock, patient getting CPR, reoperation already has an IMA from the first OR, unusable, fragile, self-destructing IMAs, and one subgroup of diabetics, obese females. Why this subgroup? In our review of 1,001 cabbage procedures and deep sternal wound infection, 6 of the 16 infections occurred in obese diabetic women, or 38%. This figure compares deep sternal wound rates of men and women, diabetic and non-diabetic, obese and non-obese patients. The rate in 28 obese diabetic females was 21.4%, 10-fold greater than the 2% rate of all of the subgroups combined. Hence the avoidance of BEMA in the subgroup of diabetics. In order to perform BEMA routinely, one needs to do routinely the things that honor and protect the IMA. Harvest the IMA the best way we know how, Protect the devascularized sternum against infection by adding multiple protective layers against infection. Review your work with transit-time fluid and epicardial ultrasound. Be patient, meticulous, and methodical. And be prepared to be no longer considered the fast surgeon. This is a brief skeletonization with the harmonic scalpel. Note that the mammary is pink, and there is some steam, but it's steam, it's not particulate matter. So I want to go to preventing deep sternal wound infection. This is probably the thing that most people don't do double mammaries because of this. In the 1001 CABG procedures from 2012, multiple infection prevention measures were sequentially introduced. The deep sternal wound infection rate reduced from 16 over 532, or 3%, to 0 over 469 for the last 4.5 years of the study. There were 12 infection prevention measures. Some were easy, no bone wax, chlorhexidine alcohol skin prep, vancomycin potent paste, and some were harder, skeletonization off pump. This diagram shows the rate drop of the last infection occurred with a red dotted line with the black arrows indicating the 8 prevention measures implemented during the study period. The key measures appear to be the change to chlorhexidine alcohol and avoidance of BEMA in this one subgroup of diabetics. Of note, infection is caused by transgression of several barriers to infection. Conversely, the prevention of infection occurs by adding multiple layers of prevention. Since the last infection in this series, which was April 2008, there has been one equivocal deep sternal wound infection in the subsequent 1149 patients. Ensuring work accuracy is the easiest to do while in the operating room. In a study of 1,000 arterial grafts with TTFM use, we compared patients with good grafts, PI less than 5, and those with PI greater than 5. MACE was significantly higher in the group with the high PI, which was largely explained by patient death. Even when the emergency patients were excluded, significant more deaths occurred in the high PI group. This bar diagram depicts the relationship between PI and MACE. Note that even when emergency cases were removed, there was still more mortality in the high PI group. And this is a TTFM unicus of a Lima to LAD graft with 4 septal perforators, all nicely in a row. Now about the mindset. Mentors, if you've never trained with anyone who performed BEMA grafting, it is best to visit surgeons with BEMA experience. Specialized CABG training may be coming soon. When cardiologists see patent Lima and Rima grafts after 15 to 20 years, you get their attention. Some BEMA and radial grafts are that's all they want. Read different types of surgeons. We need them all. Which is better, countless retrospective reviews or randomized trials? Speaking of which, let's look at ART. Why was there no difference at 10 years between BEMA and SEMA group? ART was meant to be a trial of 1 IMA versus 2 IMAs, but 40% of patients received other than intended due to crossover rates. CETA to beta, 4%, beta to CETA, 14%, CETA with a radial artery, 22%. There was no difference in the intention to treat group because both groups had essentially the same number of arterial conduits. There was a big difference in the as-treated group, significant improvement in both endpoints, all-cause mortality, and especially the composite of mortality, MI, and stroke. Experienced surgeons had much better results at 5 years for both endpoints, and the curve started to diverge at 2 to 4 years, and even with the intention to treat. Some further thoughts. Randomized clinical trials can be definitive, as in the 3 major OPCAB trials, but may not be, as in the STITCH trial. Equipoise for CETA versus beta may no longer exist for some surgeons. There are 3 levels of awareness of cardiac surgical expertise: surgeons, cardiologists, and patients. Cardiologists have known for years the benefits of TAG. For example, when speaking to Professor Raphael Moore years ago, in his unit, if a surgeon did not perform routine BEMA grafting, they would not get any referrals. Cardiologists see the untreatable vein graft disease, the hesitancy to operate on patients with patent Lima to LAD grafts, and the disabling chronic angina. Occluded vein grafts may not kill the patient, but they kill quality of life. Cardiologists know what it is to have arterial grafts last decades. They follow their patients for this long. We surgeons do not. And more patients are actually asking for arterial grafts. Here's 4 examples. This is a Lima, sequential Lima to diagonal LAD. This is a composite Lima with a Lima itself. It's Y with itself. And here's another Rima to marginal through the transverse sinus. And here's another Rima to a PDA. Note the turn point right near the pericardium. So, arterial grafting can be used in all patient subgroups with safety and attention to detail. Successful arterial grafting depends on the anastomosis, yes, the technique used, prevention of infection, a mindset to provide patients with the best available conduit, not just for some, but for all. Performing arterial grafting routinely treats all patients with the best conduits available without preferentiality, without judgment. BIMA is possibly the most important thing a surgeon can do for CABG patients. An extra 20 minutes. Where are they coming? Okay, an extra 20 minutes for an extra 20 years. You know, I think if you have proximal disease and you use arterial grafting, we cannot cure this disease, but it is the closest thing to a cure we have. Thank you.